Hello, welcome to this video of the Neurosurgery 100 series. My name is Kevin Huang from the Department of Neurosurgery at Mass General Brigham and Harvard Medical School. And it's my pleasure to be able to introduce you to the spine and to talk a little bit about back pain. We have two major goals. The first is to share why you should care about spine surgery. And the second is to review how to perform an initial back pain evaluation and to go over some tips and tricks about doing that effectively. So, why the spine? Well, the first reason is that much of neurosurgery is spine surgery. Spine surgery is very common in most neurosurgeons' practices. The most common procedures that neurosurgeons do tend to be spine surgeries. And so as a result, if you're going to be working with neurosurgical patients, you're most likely going to be seeing a lot of spine pathology. Moreover, back pain and neck pain are extremely common and they're disabling. The incidence of this is increasing every single year. And on top of that, it's increasing with an aging population. It's the #1 cause of disability in working age adults globally. And as a result, there's just a lot of it around. Moreover, the spine is just fascinating, right? It's a very complex organ. It deals with complex biomechanics and anatomy. And so you could be dealing with anything from a fracture dislocation to a deformity to even revising prior instrumentation. And so all of these can be relatively complicated problems to solve and really keeps you on your toes as a spine surgeon. There's also a wide range of pathologies that spine surgeons are dealing with, including advanced erosive and degenerative conditions producing deformity, tumors of all different shapes and sizes in the various compartments throughout the spine, and different vascular pathologies, which can affect the spine as well. It's also an area of rapidly evolving technology. That includes various types of approaches that are being refined and perfected, different types of minimally invasive fusion techniques that get better every single year, the use of robotics within spine surgery, as well as endoscopic technologies. All of these are evolving at a rapid pace, and it seems like every year there's something new and interesting that's pushing the boundaries of spine surgery. So with all of that said, how do we go about evaluating a patient coming in with back pain? And I will lump in some principles from neck pain as well. And we can start by asking, what is pain? And I like this definition, which talks about an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. And I like this for the idea that it recognizes there's both a sensory and emotional component, as well as the idea that it feels like something is being hurt, even if it isn't. And I think that is encapsulated in this quote from the Buddhist tradition, which is that pain is unavoidable, but suffering is optional. And I think that really ties it all up in the idea that we all deal with pain, right? But there's both a psychological and a sensory component to that. There are a lot of different sources of pain throughout the spine, and those can lead you down different treatment pathways. And part of a good history and a good physical is that you can start to differentiate these various causes. You know, that pain can be coming from the muscles, so it can be a myofascial type pain. It could be coming from the joints, leading to a facet-related pain. It can be coming from the nerves, so a radiculopathy or a claudicating type pain, any type of neurogenic pain. It can be coming from the discs, a discogenic pain, as well as the bones themselves. So not just the spinous processes, but the actual vertebral bodies. They can all hurt and can be associated with various pathologies. And sometimes it's not even within the muscles or the bones or the nerves. Even the skin itself, right, can be felt as back pain. And so anything in that region you really want to be thinking about and be sensitive to. Not all back pain is created equally either, right? This patient has back pain, as does this patient, as does this patient, as does this patient, right? They all have back pain. And so if you're going to do a good initial evaluation, you're going to want to be able to sort out these various types of back pain. But doing so can be really difficult because there's no objective way to externally measure someone's pain. We have to talk to them. And as a result, history can be really nuanced. Language is imprecise, but it's the only way we have of really assessing someone's pain. And you want to avoid this situation where, look, doc, it just hurts, just help me, right? You want a little more granularity. You want a better understanding of the pain than that. And you want to do so in a way that's both efficient, that's respectful of the time that you have with that patient, as well as being thorough. So these are the key history points that I think are part of a good initial back pain evaluation. The same applies for neck pain, and we'll go over each of them in turn. Right? So understanding the timing is critical. You want to know if it's an acute onset, a subacute onset, or an insidious onset of the pain, as well as any immediate preceding events. You know, if this shooting leg pain started immediately after lifting your neighbor's fridge up a flight of stairs, that's really going to help you cue in on the diagnosis, as opposed to someone whose pain has been there for as long as they can remember. You want to understand exacerbations along the way, whether or not it's episodic or it's constant, as well as has the pain evolved into something that's stable? Is it improving over time, or is it worsening? And that'll help you understand the pathologic processes that are going on. Location is obviously very critical as well. You want to know, where is the pain? And moreover, not everyone means the same thing when they say back pain, right? One person's back is another person's flank, is another person's buttocks. So really being specific, giving people reference markers. For instance, is your pain above or below the belt line? Right? They can be really helpful in just getting on the same page about where this pain is. Understanding radiation is very important, including, is it going down to the knee, past the knee? Is it going past the ankle into the foot? Is it going to the top of the foot, the bottom of the foot? Is it coming down the front or the back of the leg? These can all help you understand various dermatomes and various radiation patterns. Or is the pain non-dermatomal in distribution? So something like a burning sock-like distribution pain is going to be very different than a shooting pain down the back of the buttocks into the calf and into the bottom of the foot. The quality and the severity matter a lot, right? So finding a common language to talk about how severe the pain is can be very helpful. So that's something like the VAS scale or any type of 1 to 10 severity can be just helpful in understanding how severe it is, but also how it's evolved over time. The quality of the pain, is it stabbing, is it shooting, is it electrical, is it burning? These can help cue you in into some type of pathology as to what's going on. And then finally, which components are more severe? Does the leg hurt more than the back, or does the back hurt more than the leg? This can be really helpful in setting proper expectations and helping you formulate a good surgical plan with the patient together. Understanding exacerbating and alleviating factors can be very helpful. Is the pain worse when you're sitting, standing, or laying down? That can be very helpful because as we're sitting, there's more pressure on the discs, but the dorsal structures, the spinal canal and the foramen, they're opened up. And so pathologies that affect there are actually better when you're sitting, as opposed to when you're standing. And there's more pressure on the facets, the spinal canal is more narrow, and the foramen are more narrow. And as a result, pathologies that impact those are worse when you're standing. Any type of difference between extension and flexion can be helpful. Many people, or most people, go to the grocery store, they're using shopping carts. So a shopping cart sign where their pain is better when they're hunched over their shopping carts can be really helpful in understanding what the problem is, and as well as any progression throughout the day. In particular, pain that's worse at night, that wakes you up from sleep, especially in the context of tumors or cancer, can clue you into oncologic pain, which is classically worse in the middle of the night. You also want to understand any associated positives and negatives. Is there any hint of Cauda equina syndrome, right? So you have to ask about that, bowel and bladder incontinence, saddle anesthesia. You want to understand any associated numbness, any associated weakness, and how that has evolved over time. Don't miss signs of other pathology as well. Are there upper extremity symptoms? Is there gait instability? Is there anything to suggest a tandem stenosis where they might have cervical or thoracic stenosis and a myelopathy? You obviously want to know that beforehand if you're thinking about a lumbar procedure in someone. And then finally, any red flag signs, signs of infection or malignancy, such as unintentional weight loss, fevers, or night sweats, that type of thing. So prior non-surgical management you want to know about, including any physical therapy and any medications that have been used, and in particular, any interventional options, things like facet blocks, medial branch blocks, or epidural steroid injections. In particular, when asking about those, you want to understand, was there a diagnostic benefit versus a therapeutic benefit? In particular, was the pain better for a few days or a few weeks after this epidural steroid injection? That may clue you in as to an area that actually benefited from injection. But if you just ask, look, did it work? And you don't ask any further than that, you may miss some of those nuances. Of course, you want to know about any prior surgeries the patients had, including what was done, when it was done, and if anything was implanted. And what's often missed is just asking, did prior surgeries work, right? Whether or not they received a symptomatic benefit from the prior surgery can be really helpful in thinking about any future surgeries. On the physical exam, you want to do a thorough and targeted physical exam. You really want to have them show you where it hurts, right? On top of that, have them reproduce or at least think about the actions that reproduce their pain. It just cuts down on the ambiguity about the things you're talking about. Is their pain worse with certain maneuvers, whether that be facet loading, straight leg raise? All of these can be very helpful in localizing where the pain's coming from. And you want to conduct a thorough myotome testing, helping you differentiate potentially a foot drop from, let's say, a lumbar radiculopathy versus a more peripheral cause like a perineal neuropathy. Other key points that you don't want to miss on the physical exam, they include gait testing. You can tiptoe walk, tandem walk, heel walk. These are all really helpful, particularly for picking up subtle weaknesses. For instance, a subtle plantar flexion weakness that is rarely picked up on actual bedside testing, but if you have them do a tiptoe walk, you will see it very clearly. You want to notice their posture, you want to notice their tone, right? Spinal deformity is more common than you would think, and having patients take off heavy outerwear, taking off heavy jackets, and just getting a sense of the shape of their spine, their sagittal imbalance, and their coronal imbalance too. These can all be really helpful and help cue you into understanding their spinal shape and their spinal alignment before you're sending them for advanced testing. You do want to gain a basic familiarity with hip and shoulder maneuvers. These can be super helpful. They're really common. They can be commonly be mistaken for back and neck problems. And so if you can really help sort that out on provocation of the hip and the shoulder, that can save you and your patients a lot of consternation. And then finally, don't forget to look at old scars. Not everyone has a detailed blow-by-blow of every single surgery that they've had done. And so just examining these old scars, understanding how they've healed, where they are, can really cue you in to a lot of important details. So some closing thoughts. In conclusion, spine care is both nuanced and rewarding. It's a great field to be in. And if you're going to be a neurosurgeon, there's a really high chance you're going to be interacting with a lot of spine patients. And it can be a really great field to be in. And in order to practice that well, set yourself and your patient up for success by doing a really good initial evaluation. And you're going to have a really happy interaction if you're starting out with that strong base. Thank you so much for your time.